3 pulmonary intensivists at Baptist Hospital. I graduated from the OU program, the OU Health Science Center, not opposed to them, in 2009, and rotated with these guys when I was in school and started working for them when I got out. So part of this is most of this is going to be from an inpatient basis because that's most of what PE is, but I will throw some stuff in there about outpatient diagnosis and that sort of thing. Most of what I do is inpatient. When I first started with the group, we did have an outpatient practice, and I did office and hospital. But for about the last 3 years, I've been only in the hospital. And we closed our practice, outpatient practice, about 6 months ago. So we're all hospital-based. We have a closed ICU that we manage. And so we see lots of PEs. The thing that's important and that I want you guys to remember about PEs is know your signs and symptoms and know your risk factors. Not every person who comes in with shortness of breath needs a CT with PE technique and needs to go down that route. But you need to know what your risk factors are so that if somebody presents with them and has the signs and symptoms that could match, it's just important that you at least have that in your differential. So that's my take-home point of all this is. Make sure that you always have PE in your differential, especially on an inpatient basis, because it's definitely more common on an inpatient than outpatient. So we'll talk about what is a PE, what are the risk factors, like I said, it's super important. As far as diagnosis, how do they present, tests to figure out how to find them, algorithms are easy, something to memorize. We'll talk about treatment as far as risk stratification, as far as how do you choose what to do. We're going to go over the medicines. I didn't do a ton on the medicines, but I did do a decent amount. And then we'll talk about duration of therapy. We're also going to cover the newest guidelines from CHEST, which is the American College of Chest Physicians. They do a consensus guideline release every 4 years on the newest and the latest and greatest in antithromboembolic illness, and they just came out with a new set of guidelines in February. So what is a PE? Oh, let me start by saying that this lecture initially came from one of my physicians who lectures respiratory therapy students. So some of these slides are his, some of these have been changed, so you'll notice the font looks different in a couple different places, and that's just because I've, over the years, kind of changed it. So the base lecture is from Matthew Britt, and then I've added a bunch to it so that it's more specific for you guys and not respiratory therapists. So pulmonary embolism, by definition, is something that blocks the pulmonary vasculature. Most often we think about blood clots, but it can be anything. It can be air from putting in a central line. It can be fat embolus from a fracture of a long bone. It can be a tumor from tumor lysis syndrome. Anything that includes the pulmonary vasculature is considered a pulmonary embolism. We talk more about blood clots because that's really the only one of those that you can treat, and that's the one that we see most often. So what is the PE? It's a huge cause of death. It's a lot more common than I think we think of. 400,000 diagnoses of PE are missed in the U.S. per year. That's a lot. And most of the deaths from pulmonary emboli are people who are never diagnosed, not people that are treated. So people don't necessarily die from anticoagulation from being treated. They die from us never even thinking about it. So that's why I say it's so important to keep it in your differential. 2/3 of patients with a PE will die within an hour of ever being diagnosed, of symptom onset. Again, symptoms can be fast, furious, and the bottom one's the biggest thing for me. 25% of people with a PE, their first symptom is death. That's huge. I mean, you think about how many, of the people we miss, 25% of them are just going to die. So it's a huge deal. It's very important. Blood clots kill people, so that's why it's important to always keep it in the back of your mind, know your signs and symptoms, and know your risk factors. So you guys, have you learned about Virchow's triad yet? This is a test question. Ding, 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 ding. You'll see this somewhere. One of them is venous stasis. So anything that keeps the blood from flowing, whether it's sitting in a car ride for a long time, whether it's laying in a hospital bed for 23 hours a day. Venous stasis. Venous injury or endothelial damage. This comes in a couple of different things. We can have people that get DVTs just from getting a hit on their leg. Trauma to their leg can cause, again, venous injury can cause the blood clot of that site. Another thing that's very common is total joints. They do total knees, total hips. Again, you're getting so much vascular damage just from manipulating. You may never touch the vein, but just from manipulation in there, you're getting venous injury and endothelial damage that can promote clot formation. The other big one, and this is hugely important in the hospital, is your lines. Central lines, PICC lines, those are famous for causing blood clots. So anybody who has a big arm and has either a PICC line or a central line, you guys familiar with PICC line, central line? Anybody who has a big arm and has a line in that arm needs an ultrasound. So 9 times out of 10, that's going to be a blood clot. So again, most patients will have lots. You have a patient in the hospital who just had a total knee and is laying in bed all day. That's multiple risk factors. Hypercoagulability, and we'll go over what these are. So certain states cause you to be hypocoagulable. Cancer being the most common. Malignancy puts you in a hypercoagulable state. Pregnancy, anything with increased estrogen, and that's why oral contraceptive pills are such a big deal. Obesity, again, women who are obese tend to have more estrogen. They're in a little bit of a hypercoagulable state. So risk factors. Inherited risk factors are not as common. You have factor V Leiden. There's lots of different clotting factors. So deficiencies in one versus excessive other can cause you to be more likely to clot. Factor V, again, is the most common. Protein CNS, antithrombin 3, those are the ones we see most often. The thing that's going to clue you in that somebody could have an inherent coagulopathy is when you talk to them, he says, anybody in your family ever had a blood clot? Yeah, my brother had one, and my mom's had one. Those are generally the people that they pretty much spell it out to you, that they've had blood clot in their family. Those are the people that tend to have some sort of problem. Acquired age, the older you get, the higher risk. Smoking, obesity, again, because of the estrogen. Immobility, which kind of goes along with Birchhouse. Malignancy, pancreatic cancer is one of the biggest ones. Lung is also a big increased risk factor for blood clots. And the phospholipid antibody syndrome, I've seen it once or twice. It's not very common. Hyperhomocystinemia, I've never seen before. Oral contraceptive for hormone replacement. So again, your little old ladies who've had hysterectomies and are on progesterone or Premarin, those ladies are at higher risk. So that's another thing that you're going to do when you do find a PE is you want to know what your cause is. So Premarin, OCPs, I've had a couple of young girls that their only risk factor was oral contraceptive pills. Trauma, surgery, hospitalization, big. Infection is a smaller risk factor, but definitely there. Long haul air travel, again, is just immobility. Electronic leads into lung catheters, we talked about that. PICC lines, central lines, most common. So who do you actually do the big thrombophilia workup on? Again, these are people who have no other risk factors. You have no idea why this 28-year-old comes in with a blood clot. There's no trauma, they haven't been sitting around for a while, they don't have cancer that you know of. All of those things make you wonder, why does this person have a blood clot? And oftentimes it's their first event, so they don't have to have multiple before you realize it. Again, anybody who has a PE and doesn't have an obvious cause needs to be worked up for thrombophilia. And then family history, which we talked about. The most common coagulopathy is factor V Leiden, and we found several of those. Prothrombin gene isn't as common. Antiphospholipid is very uncommon, and so is homocystinemia. Again, this is his slide. I'll tell you factor V is the most common. Protein CNS, I have seen one or two of those. Again, not super common. Your coagulopathy causing a PE is your least frequent cause. So as far as this pathophysiology, I'm going to try not to get too bogged down in this because this slide is not very awesome. So basically you get gas exchange. So you're ventilating the area fine, you're not perfusing it. You've got something blocking the pulmonary vasculature. So where the blood comes through to pick up the oxygen and let go of the carbon dioxide is blocked. So you, in essence, get a right to left shunt, meaning blood is not getting oxygenated coming in the right side of the heart to go to the left side. You'll obviously get hypoxemia. You get an increased alveolar to arterial gradient. Again, the PO2 in the alveoli is a lot higher than the PO2 in the oxygen, and that gas exchange can't happen because the blood's just simply not going to that section of lung. So you get a VQ mismatch, or ventilation perfusion mismatch. Again, you're ventilating an area of the lung that's not being perfused. That increases your dead space. You can get a respiratory alkalosis from hyperventilation. So again, these people, they're missing a whole section of lung based on the blood clot. So again, they're not perfusing an area that they're ventilating. So what they're doing is they're having to increase their minute ventilation to be able to oxygenate enough to sustain their PO2. So you may get a blood gas. I heard you guys just have blood gases. And their PO2 may be adequate, but they could have a respiratory alkalosis. So they're breathing off CO2 because they're hyperventilating, trying to get enough oxygen. That is oftentimes a sign of a big PE. Again, they're working so hard to get enough oxygen that they're blowing off their CO2. Hemodynamic abnormalities, these are the big PEs, and these are the ones that are very scary because you never know when they're going to go. Again, it depends on the size of the embolus. It also depends on the chronicity of the embolus. There are some people that may have had a clot and noticed that they were a little bit short of breath and didn't do anything about it. We had a lady who recently came in and had been feeling a little bit short of breath for the last couple weeks. Noticed it was a little bit worse, started getting a little bit syncopal when she would stand up, but basically kind of dealt with it for a little bit and came in and had a massive saddle embolus. If this had been acute right then, she probably would have been hypotensive, tachycardic, and had been in shock. But because it had kind of happened and she'd kind of gotten used to it a little bit at a time, she didn't have quite the hemodynamic instability that you would expect for the size of the thrombus. So basically what happens is the whole right side of the heart is pumping like crazy against this big clot. And so you drop pressures, they get tachycardic, you can get right ventricular dilation and right ventricular failure in extreme cases. You can notice sometimes you'll see it on the CT scan, they'll have intraventricular flattening. You can also see it on an echocardiogram. It causes increased wall stress on the right side of the heart, trying to pump against that big old clot, and can cause ischemia. One way to tell if all this is happening on lab work is to look at your cardiac markers. We'll go over that, so just keep that in mind. Signs and symptoms, big, important. I will tell you that PEs do not read textbooks. Know your textbook symptoms for your tests and for your boards, but know that people will come in with very minimal symptoms and have a PE. So that again, risk factors and symptoms have to be in your mind. They'll be short of breath. Some people may not feel shortness of breath at all. They'll have a pleuritic chest pain, which is usually worse when they take a deep breath. Some people have this feeling of impending doom, and I'll bet you will see that somewhere. Whether it's on a test or a board, you'll see this feeling of impending doom. Cough, some people can have a dry, hacky cough, and that's their only complaint. Hemoptysis, it would be very nice if every person who had a PE came in coughing up blood, but it really doesn't happen very often. But anybody who is coughing up blood needs a CT with PE technique. Syncope, someone who's about to pass out every time they stand up, that's a bad PE. I can tell you that's a big one. Palpitations, oftentimes people with PEs can go into atrial fibrillation, so they'll feel those palpitations. Wheezing is less common, obviously leg pain, leg swelling if it's coming from a DVT. Signs, tachycardia. We had a lady who had a knee replacement, did fine, went to Jim Thorpe rehab, was doing fine, got constipated, ended up coming back to acute care to have a small bowel resection for constipation, and ended up post-operatively was on room air, felt fine, but was just had this constant tachycardia in the 120s, nobody knew why. Totally no complaints, no chest pain, no cough, no nothing except tachycardia. Again, she had risk factors. She just had her knee done, she'd been in bed all day, she'd been hospitalized, checked her, and sure enough she had a PE. So that was her only symptom, was that she was tachycardic. So that's the reason that you have to, again, think, this lady's got risk factors. I have no reason to explain her tachycardia. Her fluid status is fine. She's not in pain. Now we've got to go looking for something else. Hypoxemia, obviously. Accentuated S2, you won't see that. Don't worry about it. Fever, I've seen lots of people come in who had pneumonia and were treated in the ER, went home and didn't get better, and came back and sure enough they had a PE. That doesn't mean that every person with a fever needs a CT with PE technique. Diaphoresis, that kind of goes along with their syncope. That's usually in really big PEs. Signs of DVT, obviously, leg swelling, red hot. Cardiac murmur, not so often. JVD, that's a symptom of failure, heart failure. Cyanosis from hypoxemia and hypotension. Now, obviously, if you work in the hospital, you will see people with these symptoms all the time. You'll see people with lots of these symptoms. And that doesn't mean that every person has a PE. That's another reason why you think of your risk factors and you think of what the overall picture looks like, or else we'd be CTing everybody in the hospital. D-dimer. D-dimer is another great test question. They love D-dimer. We don't use it on an inpatient basis. D-dimer is affected by tons of things. It's not specific. Excuse me, it's not specific. So it can be elevated in lots of different things. If it's negative, it basically rules out DVT. So it's a non-specific measure for fibrinolysis. It's measured by an ELISA. It's very sensitive, meaning it's positive in the presence of disease. But it's also positive when there's any other thing going on. So it's not, a positive value doesn't really help you. It's a negative value that does. This is very helpful on an outpatient basis. If you think that somebody, you don't really think they have a PE, but they kind of have some of the symptoms, you can check a D-dimer. If your D-dimer is negative, you can pretty much say it's not a PE. So it helps in an outpatient basis. It helps in an ER setting, so you can do a really cheap D-dimer instead of doing a CT with PE technique. But as far as in the hospital where people are sick, it's not very helpful, because probably 80% of the people in the hospital right now will have a positive D-dimer. Chest x-ray. The most common finding of a PE on chest x-ray is a normal chest x-ray. So it's really not helpful. The way that it's helpful is that if you have somebody who's coming in with lots of chest pain, maybe coughing up blood, and you check an x-ray and it's normal, that's probably another clue that this could be a PE, and you've got to look for something else. You can have collapse or atelectasis, you can have consolidation. Then that's why a lot of people get treated for pneumonia. You can get small pleural effusions, you can get an elevated diaphragm from atelectasis. The uncommon findings are test questions and board questions, not something you actually ever use in practice. I've never seen Westermarck sign until I started giving this lecture, so you guys may or may not see that on a test, and we'll talk about what it is. It's basically that the vessels are dilated behind the clot. Hampton's hump, I actually saw in my ER rotation when I was by myself, scared to death, and I ordered a CT, and the physician comes in and says, cancel that CT. So he's got a Hampton's hump, and sure enough he did, and that was really the only time I've ever seen one. So I just got lucky. And I'll show you what that looks like as well. So again, mostly a normal x-ray. You can have this Westermarck sign. I'm not sure how well this shows up here, but it will probably show up better on your computer. So you notice here that you have pulmonary vasculature that goes all the way out. So this is your main pulmonary artery. And so you get these little arteries that are coming all the way out, same side, all the way down, all the way down. You notice up here we do not have any squiggly lines. So the pulmonary vasculature is not there. And you have a little bit of a dilation here. So that's your Westermarck sign. Again, I would never look at this and say, it's a PE, I'm going to treat them. It's just something to kind of lean you towards it. And again, you will not always see that. This is your Hampton's hump. And this is this little area here. Oftentimes that's an infarct, so you get a wedge-shaped infarct from the area of lung not being perfused. Oftentimes this gets treated for pneumonia until they don't get better and come back, if they come back. This, you can have cavitations, you can have effusions, very rare. This melting sign you probably never see. You won't see it on the test or anything either. So they say it heals the linear scar. I'm not really sure that I appreciate that, but there it is. You won't see that, you should not see that on the board or ECG, this is a great test question, and they love to throw this out, but I've never seen it. So you can get S1, Q3, T3. So you get a large S wave in lead 1, you get a Q wave and T wave inversion in lead 3. It's a great test question. I guarantee you will see it. If not on this test, you'll see it on your boards. So just remember that, and that's about the only place you'll get it. Just to be honest. VQ scans. When I came out of school, we learned so much about VQ scans. I was ready to give everybody a VQ scan, and we don't even hardly use it in the hospital. It's really kind of an old, we do still use it in certain times. We use it for people whose creatinine is not good enough to get a CT scan. So if somebody can't have contrast, whether they have a contrast allergy, or if they have renal impairment, pregnant women, you try not to irradiate as much as you can. So those people we can still use VQ scans for. So what is a VQ scan? Basically, you inhale a radioactive compound. So that means it's going into the lungs and all the areas that you're ventilating. You then get a radioactive compound injected into the vein that then goes to the pulmonary artery, and it shows that radioactivity of the area that's perfused. You can see that little white area. That's your clot. So you're not getting any of the blood substance past that. So what the radiologist does, ion ray VQ scans, they're very complicated. They'll notice that there's a ventilation perfusion mismatch, and that's what a VQ scan tells you. VQ scans aren't always as helpful as they could be because they're either high probability, intermediate, or low probability. So intermediate really helps you none at all. If you think somebody has a PE and you're pretty confident clinically that they have one and you get a high probability, you're comfortable with anticoagulating. If you have somebody that you don't really think had one and it's a low probability, you're pretty comfortable saying that's not what it is. But most of the time you get an intermediate scan, so it's not horribly helpful. This is a VQ scan. This looks very subjective to read, if you ask me. So the way that VQ scans work is if somebody has an area of consolidation, let's say they've got a bad pneumonia, or they've got a pleural effusion, you're going to get a mismatch on those areas. So people who have a clear chest x-ray are the people who are the best for VQ scans, because that area of consolidation can kind of mess you up when you're trying to read this. So if you look at it, this side is your ventilation. So you notice the whole lung is ventilated. Over here we have all these breaks. These are all little areas of hypoperfusion. And that's your area of PE, and they kind of decide about whether that's low, intermediate, or high probability. CT scans is really what we use now. This says new standard because I bet you Dr. Britt did this lecture 15 years ago. But that is what we use as a CT scan. The actual gold standard is pulmonary angiography, which is where you actually do a heart cath, basically. And so that's very invasive, so we use CT scans. The negative predictive value for a CT scan is 99%, so that means if they don't have one, you will know it. With the caveat being that if they're very large, 350, 400, they're a lot less reliable. So have you guys had CT yet for radiology? So you're kind of familiar with what we're looking at a little bit. So when you're looking at a CT scan, you're looking through their feet to their head. This is anterior, this is posterior with vertebra. This is your right side, this is your left side. This is obviously the heart here in the middle. Bet you guys got that by now. So you have your pulmonary artery coming out, it branches into the right and the left. The thing I always learned about, I actually did a radiology rotation in school, is look for the Krispy Kreme. And so if you notice, this white is what the vessel should look like with contrast. See this dark area? That's all PE, that's all clot. Clot on this side, clot on that side. So this kind of looks like a Krispy Kreme donut. That's why they say it looks like a donut. Again, so these are pretty big PEs up here. You're still almost in the main pulmonary artery at this point. When they get farther subsegmental down, you'll see a little bit less. These are both pretty big PEs. Pulmonary angiography is the gold standard. We don't do them very often because, again, they're invasive. There's lots of contrast. But it gives you a very pretty picture of the pulmonary vasculature. Again, you can see all these pulmonary arteries going all the way out, looking very pretty. Over here, it just stops. And that means you've got a large clot blocking the pulmonary arteries. So here's Westermarck sign again. We go over it a lot, even though you don't see it very much. I should probably adjust some of these slides, but this is actually a pretty good picture of it. So you can see up here, you've got these little vessels that go all the way out. Well, now you have this big, huge dilatation here, and very little vasculature coming out. Your PE's here, here, here. Notice this goes all the way down, and it's nice and pretty. I had never even heard of Westermarck sign until I had his slide, so I would not think that you would see that, but it's there. MR, angiogram, we don't use those here. I think that's probably going to be something that gets bigger. The thing with me is if I've got someone with a big PE, the last thing I want to do is stick them in an MRI for 30 minutes to find out if they've got one or not. CTs are quick and easy, and you get them off the back and in a good place instead of them coding in a CT scanner. But you can get an MRI, again, it maps out the vasculature, but it's very rare. So the algorithms are always fun. That way, when I always liked PE when I was a student because there's so much stuff that you don't know when you get out. You think, gosh, I have all this knowledge, and you get there and there's all this crap that you don't know, and that's okay. But with PEs, it was always pretty simple. You know, you have a PE, okay, this is what you do. There are guidelines, it was very specific, so you felt like you were good. There wasn't a whole lot of thinking. Now we have all these new agents, so there's a little bit more thinking involved. So if you're in an outpatient basis, and somebody comes in and they said, you know, I'm short of breath, and I've got a little bit of a catch when I try and take a deep breath, you can check a D-dimer in your office. If the D-dimer is negative, you're done. You can say that there's no PE, and you can feel confident in that. If it's elevated, now you have to go do a CT chest. If you do this first generation, second generation, scanners used to, again, probably 15 years ago, the newer scanners are a lot better slices, better resolution. So if you're in Podunk, Oklahoma, that has a little teeny tiny ER and it's an old, small facility, they may have an older generation scanner. They may not get as good of films. And so in those situations, a first generation scanner, I should say, first generation is back in the day, and your no isn't as obvious. If it says no PE, but yet you're still pretty worried about it, this patient's coughing up blood, they have active cancer, and you think, gosh, this just really could be a PE, then you can ultrasound their legs. Sometimes in patients who you can't get a CT on because of their renal function, you can scan their legs. And a lot of times you'll get that DVT, and then you can just assume that it's a PE without even having to go that far. If the ultrasound on their legs is positive, obviously they have a DVT. You can assume they have a PE, and you're going to treat them the same. You're going to anticoagulate them. If the ultrasound is negative for DVT, but you're still worried about it, you're still not sure, then you can continue to either do serial ultrasounds of their legs, or you could do a pulmonary angiogram. I think that your level of suspicion has to be pretty darn high before you're going to subject somebody to a pulmonary angiogram. If it's OU Medical Center, or it's Baptist, or it's St. Anthony, or one of the larger big center hospitals, and the scanner says they don't have a PE, you can pretty much guess that they don't have a PE. This first generation, third generation isn't as big of a deal as it used to be. So now that you know have a PE, now what do you do? Used to, back in my day, it was real simple. We had warfarin, was our only oral agent. So it was pretty simple when you decided what you were going to treat this person with. You're going to put them on heparin or Levinox, and you're going to transition them to warfarin. Now we have all these newer agents, and we'll talk about that. One thing you have to think of the first thing you think of when you have a PE is this person hemodynamically stable? Do I need to start thinking of TPA or thrombolysis or something else other than just anticoagulation? The way to do that is looking at hemodynamic stability. Are they hypotensive? When I say tachycardic, if they're 105 and they look okay, you're not going to stress out about it. If they're tacking in the 120s, 130s, that tells you they're stressed. And those are people who are more at risk for complications. We talked a little bit about right heart strain. Another evidence of large PEs is when you check biomarkers, being brain natriuretic peptide and troponin. If those are elevated, that's evidence that their right heart is straining. Again, it's working hard. It's going to release brain natriuretic peptide. You're going to get a little bit of ischemia, which is going to bump your troponin a little bit. When I'm talking about elevated troponins, usually it's maybe 1. Usually it's less than 1. So it's not a huge bump, but any little bump above normal can be evidence of strain. If those are elevated, then you need to get an echocardiogram. You guys know about echocardiograms? I hate to keep asking stuff. I just know that you just started in January, so I don't want to talk about things and just assume that you know what I'm talking about. So an echocardiogram is basically an ultrasound of your heart. And what it looks at is it looks at all of your heart valves, it looks at your heart muscle, it can measure how well your heart is pumping. So they can check your right ventricle and tell you, does that right ventricle look strained? Does it look like it's starting to fail because it's pumping against this big old honking clot? So you don't always have to get an echo on every PE, but if you have a PE and you check these biomarkers of your brain natriuretic peptide and troponin, and they're elevated, you need to get an echo. Or if it's a big clot, I mean, if you've got a big main pulmonary artery clot, you should probably get an echo and make sure. If it's a little subsegmental heart PE down in the periphery, they look like they're doing okay. You check a BNP and a troponin and it's normal, you don't necessarily need an echo. And this is all inpatient. You wouldn't be doing this work as an outpatient. So an echo, I've had a couple people with PEs diagnosed on echo, but it's unusual. It really doesn't help you diagnose. It just tells you how much strain is this person having from this clot? How hard is their heart working to overcome this clot? In normotensive patients that you look at that look fine, vital signs are okay, they may be a little hypoxemic, a little tachycardic, they look okay. If they've got right ventricle dysfunction, that's an independent risk factor for death. So that's why it's important. Even though they may look okay, if their heart is straining and they're getting heart strain from this PE, then it's a risk factor for death. This McConnell sign, never heard of it, you'll never hear of it, but RV dysfunction with apical wall sparing, I think that's probably a medical board question, but not something good. So what do you do first? When you find out that somebody has a PE, the first thing you do is anticoagulate them. You have two options. You have a heparin drip, which is unfractionated heparin, and you have Lovenox, which is low molecular weight heparin. Unfractionated heparin is usually a weight-based drip. Most of your facilities that you go to are going to have a protocol. So when you do the order, you say, start heparin drip, weight-based protocol. And what's great is the nurses do everything. That's all you have to write. You don't have to calculate anything, you don't have to calculate the dose. So what they'll do is they'll give them a bolus of a certain amount of so many units per kilogram, and then they'll start the drip at a certain number. You check a PTT, which is how you measure heparin, and you measure how thin their blood is, and then they'll base the dose, they'll dose adjust the drip based on a PTT. So usually it's about every 4 hours they'll check it, and as it's stable, they check it further and further out. But there's a protocol that lists it all out and tells the nurses exactly what to do. You guys don't even have to know all that, which is wonderful. The reason that we like heparin is because it's easily reversible. It's very short acting. So if you have somebody that you think might need to have to go to surgery, like at OU, where you've got these trauma patients that may have to go back and forth to the OR for repair of various orthopedic injuries, then heparin's a good idea because it's something that's reversed easily so they can go to surgery. It's also great in people who have a high bleeding risk, and the reason again is because it's short acting, it's reversible, and we can get rid of it in a hurry. So if you have somebody who has a GI bleed, and has just had a GI bleed and is in the hospital and now has a PE. You'd like to use something short-acting so that if you start that heparin drip and they start to bleed, you can get rid of it in a hurry. You can't use it in people who have heparin-induced thrombocytopenia. Some people get hit, and basically what happens is they start losing their platelets. They kill off their own platelets. It can happen in people who, there's no way to look at somebody and know that it happens. The way that you do it is you look at their platelets, and if they drop by more than 50% in 2 weeks, then that's somebody that you have to look for hit in, and we'll go over a little bit about that later. And then low molecular weight heparin, that's Lovenox. I like to use it as Lovenox because it's an easier word and it's shorter, but just know that that's low molecular weight heparin. It's more specific dose response, so we know what it does. We give you a dose that lasts 12 hours. It's not like heparin where the levels can go up and down. You generally dose it at a milligram per kilogram Q12 hours. Now, when you have an obese person who's 178 kilos, that makes us a little bit nervous. In theory, they say you can dose at 178 milligrams Q12. My guys like to stop at 100, just because in obese people we don't totally know how that's metabolized. The thing about Lovenox that you need to know is it is metabolized in the kidney, so people with a creatinine clearance less than 30 only get it once a day. Women who are pregnant have to have Lovenox. They can't take warfarin, and a lot of newer agents are contraindicated. So these women will go home and give themselves sub-Q injections of Lovenox twice a day. With women in pregnancy, because they're constantly gaining weight throughout the pregnancy, their dose is going to change. So oftentimes with those patients, you'll actually measure a factor 10A. Factor 10A is a serum blood test. It measures, basically, is your Lovenox therapeutic. The only thing about it is it takes a couple of days to get back, and it has to be drawn 4 hours after the Lovenox dose is given. So if you're in a hospital setting and you're wanting to check a 10A, it's very specific that you draw the blood 4 hours after the med is given. Again, we talked about obesity. You'll find that obesity and medicine don't go together. People who are very large, we don't know how to dose medicine for people who are 400 pounds. We're seeing more and more of them. CT scanners don't hold people that are 400 pounds. MRIs don't hold people that are 400 pounds. So obesity is a big problem. And we don't really know how reliable Lovenox is in people who are morbidly obese. Again, my guys are comfortable stopping at 100 milligrams per kilogram. Then you can check a 10A level if you're worried. But I would be very worried putting somebody on 175 milligrams of Lovenox. That's just a lot. High risk of bleeding. Oral agents. This used to be super easy. It was Coumadin. Now we have, again, these are so much easier by the trade names, so I put them both on there, but I'm a trade name person. Xarelto, Eliquis, Pradaxa, and Sabeza. Sabeza is a very new one. They've kind of grouped these into the non-vitamin K oral anticoagulants. We're using these more and more because they're easier on the patient and they're easier on us. So warfarin. Warfarin is a vitamin K antagonist. It is rat poison. The problem with Coumadin is it's very specific on how it's metabolized, and everybody's different. I may have a 150 kilogram guy who needs a milligram a day, and I'll have a little 78-pound old lady who needs 8 milligrams a day. There is no method to the madness on who's going to need what. You basically start at 5 milligrams, and you just kind of keep going one way or the other until it's right. So there's no, you'll get things from pharmacy that'll tell you if their INR is 3.2 to cruise the D-spot. We just kind of just throw it out there and guess, to be quite honest with you. There's not a great way of, doing Coumadin because everybody's so different on how they metabolize it, which is why we're getting away from it. The problem with Coumadin also is obviously they have to have blood draws. And in the beginning, when you first get somebody on it, even though they're therapeutic, you're still going to have to check their blood levels about twice a week until you're confident. And some people will take months until you get them on the right dose. And then they'll change the medicines or the diet and you start all over again. With Coumadin, you have to start with either a heparin drip or Lovenox, and you have to have concurrent therapy for 5 days and until the INR is greater than 2 for 2 consecutive days. So you start the Lovenox and you start Coumadin day 1. They have to have 5 days of Lovenox and their INR has to be greater than 2 for 2 consecutive days before you can stop it. It has to do with clot degradation, and there's a theory that there's a school of thought that says that Coumadin actually makes you a little bit hypercoagulable in the beginning. The biggest reason that we cover them is that we want that clot to degrade, and so we need the low molecular weight heparin or the Lovenox for 5 days. And again, the therapeutic number for INR is 2 to 3. So that's why Coumadin is very complicated. You don't really know what dose to give. You're not really guessing. It's an educated guess, but you're also having to get lab work, and the patient's having to come back, and they have to be reliable that they're going to come back. We've had people who just didn't want to follow up with Coumadin. They come in 2 months later, and their INR 7, 9, and now they have a head bleed. So it's kind of a dangerous medicine. Xarelto, you've all seen the commercials. Has your loved one died of bleeding from Xarelto? Well, Xarelto is a blood thinner. So you are at risk for bleeding, and that's what we tell all of our patients. Xarelto is a blood thinner. You're at high risk for bleeding. Xarelto is a factor 10A inhibitor. You have to do a loading dose for it. And one thing that, if you don't know this already, with these medicines, with Pradaxa, Eliquis, Xarelto, they're also used for anticoagulation and atrial fib, but their doses are different. So know that when you get down the road, the dose for PE in these medicines is not necessarily the dose for AFib. So with Xarelto, you load them with 15 milligrams twice a day for 21 days, and then they go back to 20 milligrams at bedtime. The important thing about Xarelto is that it has to be taken with a meal, preferably their largest meal of the day. So I don't usually tell people to take it at dinner, which is what the box says, because some people are big meal, maybe lunch. So you just tell them to take it with their largest meal. A couple of problems that could become problems, and we don't necessarily know yet, is you get these little ladies, or even people who, when they get sick, they stop eating and they take their Xarelto. And we don't really know if it's metabolized and if it's still steady state at that point. That's something that's going to come out down the road. These are new medicines, and we don't know everything. The other thing that I'm questioning, and I can't find anybody who knows the answer, is how is this affected by tube feeding? People are in the hospital and they're on constant tube feeding, and you're giving their Xarelto with the evening meal. I don't know if it's metabolized. I'm not sure if they're getting the dose that they're supposed to. Again, these newer medicines haven't been studied as much as the old faithful Coumadin. You cannot use Lovenox with people with kidney disease. It's contraindicated. Supposedly, Xarelto has a lower incidence of GI bleeding and intracranial hemorrhage than Coumadin. And again, the difficult thing is that if you have somebody who has Coumadin who has a head bleed, you can reverse it with either vitamin K or fresh frozen plasma. If you have somebody on Xarelto who has a major bleed, you can't reverse it. And so it becomes a big problem. Eliquis, which is my personal favorite, apixaban, it's another factor 10A inhibitor. With this one, you give 10 milligrams a day, twice a day, for 7 days, and then you back off to 5 milligrams BID. The good news about Eliquis is you don't have to dose adjust for renal disease. Again, the dose is different in AFib, so you may see different dosages. They also don't load in AFib. The great thing about Eliquis is that Eliquis actually has a better bleeding profile than aspirin. So it's supposedly, in the studies that we have, has a lower risk of bleeding than aspirin. You cannot use it in anyone with a Q score of C, which is just basically a liver. You don't want to use it in patients with liver disease. Patients with liver disease have coagulopathies because a lot of your clotting factors are made in your liver. And so they tend to have INRs of 2 or 3 all by themselves, so that can help it. They tend to not have any platelets because that also goes along with liver disease. So those people, you have to be very careful with using any blood thinners. Pradaxa, was started out used in AFib. It was used only in AFib. They are one of the more recent ones to get a PE indication. The difference with Pradaxa and the Saveza is that you have to have 5 days of heparin or Lovenox before you start these medicines. With Eliquis, you can either start them on Eliquis right away, which we don't recommend, but you could, or you can have them on Lovenox for a couple days, check them, they're doing okay, switch them over to Eliquis, and they're done. You don't have to do the full 5 days of therapy. But with Pradaxa and Saveza, you have to have 5 days of dual therapy with Lovenox or heparin. Saveza I've only seen used once. These drugs are super expensive because they're brand new. Saveza also has to be renally dosed, and you can't use it in renal failures. People whose creatinine clearance is less than 15. So I'm not paid by Eliquis, but Eliquis has been the easiest one for us to use. The other thing to keep in mind with these agents is because they're expensive, insurance doesn't want to pay for them. So you have to be really careful when you're having somebody in the hospital and you're sending home on Eliquis that you find out that their insurance is going to pay for it first. Because what will happen is you'll send somebody out with a script and say, go get your Eliquis, and they'll get to the pharmacy and they'll say, we need a prior auth, which means they have to call the doctor has to fill out all these forms, it has to come back, and it could be a week before they get their medicine, and now you've sent someone home with a PE without blood thinner. Case management will help do all that work with you, but just know that it's not as easy as just saying, go get your Eliquis. Because insurance companies, they're getting better about it because it's cheaper to pay for Eliquis than it is for them to pay for lab draws with Coumadin. But it's still a little bit slow. So these are other agents that are very rare, only going to be used in the hospital. Arixtra has anti-10A activity. It's a sub-Q injection once daily. You don't have to dose adjustment. You don't have to dose adjust it. The good thing for this is you can use it in people who've had HIT. You can't use Lovenox or heparin in anybody who's had a history of heparin-induced thrombocytopenia. The problem is you can't use it in renal patients. So anybody whose creatinine clearance is less than 30. Argatroban is a drip. It's a direct thrombin inhibitor. It's very rare to use it in the hospital. It is a drip, so it's obviously only used in the hospital. I'm not going to go over it a lot because it's not real common. The big ones for you to know are the Eliquis, Xarelto, Pradaxa, and warfarin. So complications of blood thinning, HIT. Again, it can happen with heparin or Lovenox. It happens less so with Lovenox than it does with heparin. You get an antibody against the platelet factor 4 complex, and it basically chews up the platelets. The only time you worry about HIT is if you notice that someone's platelets have dropped by 50% in 2 weeks. In the hospital, this can happen with sepsis, it can happen with CRRT dialysis, but for the most part, you just really, if you have somebody on a blood thinner, you need to keep track of what their platelets look like in the hospital. If you suspect that they have them, what happened there? Do you guys can you still see it?
Just move the mouse.
Is it still in here?
It's not on that.
Okay, well, if you guys have it, I'm good.
Oh, I just moved.
No, no, we don't.
We have it on our laptop.
There you
You
go.
can see it.
Oh, see the ball? Do they call it the ball? Is that what they call it? Okay, see the ball. McNeil brought that one from up here, Oh, okay. So, you know, we're a HIT panel. A HIT panel's gonna take like a week to send out that. So what you'll do is you'll stop all heparin products and you'll start on either Arixtra or Fondaparinux, and you'll stop any Lovenox or heparin. Another option for treating PEs is thrombolytics. When you use anticoagulants, oral anticoagulants like Coumadin, Lovenox, such and such, you are not breaking up the clot. All you're doing is stabilizing the clot, and the body will get rid of it. It will break it down. It takes about 2 weeks. You're not actually busting the clot. Those medicines are not clot busters. For people who have very severe PEs and are hemodynamically unstable, that is the only indication for using TPA. You've heard of TPA being used in strokes. It's the same medicine, and it's used for PE. There's a difference in dosing, and all hospitals will have a TPA protocol for stroke and a TPA protocol for PE, so I'm not going to go over what the protocol is. The problem is there's really no difference in mortality for recurrent PE in doing a thrombolytic. The risk of bleeding is huge. There's a whole list of things that you can't give TPA for. People who've had trauma within the last 6 months, anybody who's had a head bleed. So there's criteria on whether or not you could even use TPA. The only time that you use TPA is somebody who's basically going to die if you don't. That's really our criteria for when we use it. If we have somebody that can be anticoagulated and is hemodynamically stable, their blood pressure is okay, their oxygenation is okay, then we're going to use a blood thinner. If we have somebody who comes in who is on a ventilator, not oxygenating, well, is hypotensive, that's someone we're going to consider TPA. And it will actually go in and break up the clot. The other option is surgical embolectomy, where they actually go in, open the chest, open the pulmonary artery, and take the clot out. Again, this is only used when you don't have an option. It's only possible at certain facilities. I know OU do, I know that Baptist does them. I would assume that OU does it as well, but I don't know that you could go to St. Anthony's or some of the other local hospitals and get a thrombectomy. It's done by the cardiothoracic surgeons. It's kind of the same process as a cabbage. You cut the sternum, open the chest, put them on pump, and you actually pull the clot out. It's kind of impressive because it comes out in like a tree, kind of like an anatomy. When you had the little rubber that was in the heart and then pulled it out and it was red like the heart, like the arteries. It looks like that when they pull it out. And And it can be safe. I've seen it done a couple of different times. People did well, but again, it's just such a big surgery that you only do it for people who will probably die if you don't. Catheter-directed embolectomy. I think this is basically a little bit of a newer technology. They go in and put in a catheter in the groin, and they basically put in a pulmonary catheter, and they suck the clot out, run it through a filter, and then put the blood back through the femoral vein. So the idea is that you're just sucking the clot out, filtering it, putting the blood back in. Kind of sounds like it's good in theory, but the one time we tried it at Baptist, it didn't work, and the patient put it on the table and ended up getting a thrombectomy. I think it probably works in some instances, but again, it's a new thing, and it's not quite perfected yet. It can be performed up to 5 days after the event. You don't want to do these too late, and the reason if you do them later, the clot is a lot more solidified and it's not as easy to get out. An IVC filter, these used to be the big thing. They would put these filters in, and basically the thought was, you put this, it looks like an upside down drink umbrella, into the inferior vena cava, and clot from the legs or pelvis comes and gets caught by this filter, and it won't go to the lung. We do still use these. Interventional radiology puts them in. It's actually a pretty easy procedure. They put a little teeny tiny incision in the neck. They send it down into the vena cava, and then they open it up, and it looks just like that, upside down drink umbrella. And it catches the clot. You have a 5% risk of recurrent PE with those. These are kind of falling out of favor, and part of the reason is that somebody will get one of these put in, they'll be discharged from the hospital, they'll get lost to follow-up, and these are, you can get clots on a filter just because it's a foreign body. So they're very thrombophilic in and of themselves, so you don't want to just leave the filter in. These people, you still have to anticoagulate again, because you have to protect that filter. It's something that's just sitting in the vena cava, and if it clots off, they lose blood flow to their legs. All venous return to their legs swell up huge, and it's very bad. So the important thing about this is you only do an inferior vena cava filter in somebody who cannot be anticoagulated. OU used to do them quite a bit on their trauma patients because they didn't want those people to have blood clots because they knew they couldn't give them blood thinner because they either had traumatic brain injuries or some high bleeding risk. So they put filters in basically when they came in so they wouldn't have to worry about blood clots. They don't so much do that anymore. If you've got somebody who has a PE, and you know you can't anticoagulate them, you can protect them with the filter until that process goes away. Then you can give them low-dose anticoagulation just to protect that filter, and then after whatever their risk factor is better, you can take that filter out and anticoagulate them. But they're now removable, and interventional radiology pulls them out just like they put them in. I always thought that there was this real pretty way of taking them out that was really black and white, but they basically go in there just fishing. They have a hook, and they're just kind of trying to hook it. It's like playing that little game, you know, where you pick up the little stuffed animal or whatever, and that's kind of what they do. I was a little bit surprised when I saw them trying to pull it out, but it wasn't quite as exact as I had pictured. So, another algorithm. If you have somebody who has a PE, you're going to risk stratify. Are they hemodynamically stable? If so, you're going to anticoagulate. If not, you're going to consider TPA or a thrombectomy. Once you give them TPA, you will eventually still give them heparin. Once you get that initial clot kind of broken up, now you'll go back to full dose anticoagulation, but you have to wait, I want to say you have to wait 72 hours before you can give them anticoagulant after giving them TPA. So again, you're going to start with either heparin or Lovenox. There are some schools of thought that say that you can start with Eliquis if it's a minor PE, but my guys aren't brave enough to do that yet, so we'll wait for a little bit more evidence before we do that. But you technically could. So you're going to start on heparin or Lovenox, and you're going to switch them over to an oral blood thinner. You're going to treat them for 3 months. We're going to go over duration of therapy. If it's an identifiable risk factor that gave them a blood clot, they had a car wreck, they had trauma, they had a knee surgery, they had some kind of hospitalization, you know what caused it, you're going to treat them for 3 months, and you're done. If it turns out that they have a coagulopathy, they have factor V Leiden, protein CNS deficiency, something that's not going to go away, they get treatment for life. Also, if somebody has active cancer is their hypercoagulable state, and until that's gone, if it's gone, they're going to continue on a blood thinner for a lifetime. So now we'll talk about the chest guidelines. This is going to be short. You guys are going to be, we might just jump into the next one and be done, if that's okay with you, unless you just want to stay here for fun. Okay, so we talked a little bit about chest. Again, it's the American College of Chest Physicians. It's a worldwide group of pulmonologists and intensivists who sit down together and do a consensus paper every 4 years on what their newest guidelines are. We've kind of been waiting for these guidelines to happen because since the last ones in 2012, we've gotten all of these new oral medicines. There was all this discussion about sending people home from the ER with PEs and DVTs. And it happened. And what's bad is there's not really great guidelines to say that we should do that. And we get people whose legs are this big with a massive PE, and they're like, well, I almost said the hospital, I was just at so-and-so hospital the other day, and they sent me out with Eliquis. Well, the clot broke loose, and now they've got a massive PE. We had another guy who, actually at Baptist, who looked good, little PE, not hypoxemic at all. So they said, okay, well, you can go ahead and get treated at home, and if anything happens, come back. And they give him his Eliquis, and he goes to his pharmacy. They don't give him any anticoagulation in the ER. Goes to the pharmacy, and they say you have to have a prior off. And while he's waiting, his pain gets so bad that he comes back to the hospital and ends up getting admitted and put on Lovenox. So there are some schools of thought, and you may see this in your rotations, that some ER doctors are comfortable with sending people home and treating as an outpatient. But we're not real stoked about that because 25% of these people are going to die before they ever have a symptom. So my guys are not that bright. So treatment guidelines. They actually now have come out and said that they recommend the newer agents over warfarin, which is a huge switch. Again, warfarin is very dose specific. People may be spending days subtherapeutic and you don't know it. It's just too unreliable. So they found that they really like these newer agents better, and they have been shown so far in early enough studies to get FDA approved, that they actually have lower bleeding risk than Coumadin. They also recommend low molecular weight heparin, which is Lovenox, over Coumadin or the newer agents in anybody who has blood clots related to cancer. So let me say that in easier terms than all of that. If you have somebody who has an active cancer, they recommend using Lovenox. So they're going to go home and sub-Q injections twice a day instead of using an oral agent. And the only instance that that's favorable is in people who have cancer or who have active cancer. Now, if they had breast cancer back in the 80s, you don't care. That doesn't mean they have an active cancer. If they're getting chemotherapy or radiation because they have prostate cancer, that's an active cancer. So if they're actively getting treated or they have stage 4 disease that can't be treated, those people are active cancer and they're going to be put on Lovenox. When they talk about treatment agents of choice, some agents are disease specific. We talked about cancer, you're going to use Lovenox. Liver disease, all of the newer agents are contraindicated in people with severe liver disease. Now, there are varying levels of liver disease, and I'm not going to go over all that in nauseam, but people who have end-stage liver disease with cirrhosis, they recommend Coumadin, which is really difficult because their INRs are already out anyway. But renal disease, people who have a creatinine clearance less than 30, you can't use the newer agents, so people on dialysis have to be on warfarin. People who have poor compliance, we get that all the time, that you have a homeless guy who now has a PE. Well, he's probably not going to make it to the clinic every week to get his INR checked. So sometimes those people, it's better to just put them on these agents. Or you have an older person who's not mobile and isn't able to get out of the home very easily. Those people, these agents are a lot easier because you're not having to go get blood checked. If they've had a history of GI bleed, that's kind of tricky. Warfarin's a great idea because it can be reversed, but Eliquis has a lower bleeding profile. So it kind of depends on how fresh out they are from the bleed. If they've just bled in the last 6 months, I probably wouldn't use Eliquis. I'd use warfarin. It would be reversible when they come back into the hospital if they rebleed. If it's somebody who's had a history of GI bleed 10 years ago, then they can be on Eliquis. If you're using a thrombolytic, if you ever have, go ahead, I'm sorry.
I just had a question. My mom is on Coumadin daily, and every time she has to have a surgery, they give her Lovenox injections.
Yes.
Is that so like they can stay, they know how many milligrams she's having?
It's because that way we know what she's getting. When you have somebody on Coumadin, you can't do surgery if their INR is 2, so you can't do somebody on surgery. But what you can do is, it takes 3 or 4 days for Coumadin to get out of the system. So you don't want to stop their Coumadin and wait 5 days, because now they're unprotected for 5 days.
Okay.
For those people, you can bridge them with Lovenox. You put them on Lovenox. It's a 12-hour drug. You hold the Lovenox the night before their surgery. If they have their surgery, and they can start their blood thinner as soon as the surgeon's comfortable. So by doing that, you have a much shorter period off blood thinners than you do if you're just stopping the Coumadin and waiting for them to go down. I didn't even cover that in here. People on any of these blood thinners will be bridged for surgery. Eliquis, you have to stop for a week. Most of these oral thinners, you stop for at least a week before surgery, and surgeons may have a different preference. And all of those people, you'll stop their medicine and start them on Lovenox. And the reason is Lovenox is shorter acting. You'll hold it the night of surgery, and then they can get back on immediately after surgery, as soon as the surgeon's comfortable. I didn't put that in here. Thank you for saying that, because I didn't realize that wasn't in here. If you're using warfarin, again, we talked about the fact that you have to have dual therapy for 5 days. And again, you can start Coumadin on day 1, because it's going to take 3 or 4 days for their INR to come out to where it's going to be on that dose. That's the other thing with Coumadin, and I think it's going to get worse as people stop using it, is that Coumadin is kind of an art to know how to use it. And that's the reason why we can give you guidelines, and I'm sure pharmacy has this neat piece of paper that I got that told me how to do it, but it doesn't really work that way, because everybody's so different. And once people get used to using these Eliquis drugs, or the ones that they don't have to measure, they're going to kind of forget how to do it. And so, again, it takes 2 or 3 days for Coumadin to actually start doing its thing. So somebody's INR may be normal for 3 days, and then it'll start creeping up, and then it may shoot up. And so that's another reason why you hold Coumadin for several days, is it takes a while for it to get on board. We are chickens. My physicians are chickens. They're older guys. They've been doing this for a long time. And so when we have somebody who's had a massive PE, like a huge big saddle, like the lady that we actually have right now, we technically could stop the Lovenox after 5 days. But we're chicken, and we know this is a big clot, and so we tend to leave it on a little bit longer. So we may have them on 7 days before we switch them to Eliquis. Just because we want to make sure that we're getting as much clot degradation as we can, and we want to make sure that they're going to do okay before we stop something that we can manipulate very quickly. So when we talk about duration of therapy, there's actually quite a bit of guidelines that have come out for that this time. Used to be, it was 3 months for DVT, 6 months for PE, and then you just kind of guessed afterwards. Now they're recommending 3 months for everybody who's had a PE, unless it's an active cancer or a risk factor that doesn't go away. They're coming out with newer guidelines. The newest guidelines came out and said that one thing that you can do as an outpatient, if you're trying to be the one to decide whether or not you're going to stop therapy, is you can check a D-dimer. If the D-dimer is elevated, they have a, I believe it's a 5 times, it doubles the risk. If their D-dimer is positive at the time that you're going to stop their therapy after 3 months, and their D-dimer is positive, they have a double risk of recurrence. So the recommendations in that case are, it's up to you, but I would probably continue it and then reevaluate yearly to see if we can get rid of that. Men have a higher risk of recurrence than women do. Older people have a higher risk of recurrence than younger people do. So men have a 75% risk of recurrence. It's just much higher than women, but if their D-dimer is negative, the risk is only 25% over 5 years. Women with a negative D-dimer have a 15% risk. So the thing to keep in mind is that once you've had one, you're always at an increased risk for another. If somebody's had a repeat event, used to be that we said if you had a repeat event, we treat forever. The newer guidelines are saying 3 months. I think if it's me and I have a recurrent one, I'm just going to stay on blood thinner, because I know that 25% of the time I have a blood clot, I'm going to die. So although the guidelines say 3 months, we're a little bit hesitant to stop that. The other thing is risk factors. If they've got a huge risk factor for bleeding, they're an little old lady who might be a fall risk, you're not real stoked about having them on Coumadin or a blood thinner, because they could fall and have a head bleed. So if somebody has real high risk factors for bleeding, such as falls, we had a lady just today actually who might live in an abusive home, and although she denies it and denies wanting to do anything about it, we still have to keep in mind that we're now sending a lady who's anticoagulated into a home where she may or may not be abused. So it's just things like that that you have to think of when you're trying to decide, is the risk of anticoagulation less than the risk of clot? And there's no good answer for that. That's going to vary. Some other recommendations, again, I told you that they don't recommend IVC filters on anybody who can tolerate anticoagulation. And if you do have to place one, make sure on follow-up that you have a means to get rid of it, that you have someone who's going to follow up. We don't have an outpatient office anymore, so this is kind of a challenge for us that we have to contact their primary care physicians or their cardiologist and make sure that these filters get removed. People get sued because they don't have plans in place to remember that somebody has a filter and that filter falls off. And so that's a big problem. And that's part of the reason they're falling out of favor, is that follow-up's not happening if you were getting like them. Another recommendation, which I was talking to Dr. Huckheim, one of my doctors, about it, and he's not real stoked about this, the idea of adding aspirin. If you decide that after 3 months you're going to stop anticoagulation, they're recommending aspirin. There's really no evidence to show that it makes a difference, but they think, huh, can't hurt. So if there's no contraindication to aspirin, the one thing they